Okay, so good morning, everybody, or good day if you're playing this in catch up. My name's Caroline Miller. I'm a consultant in metabolic medicine up in Scotland, but you can find me in the inner circle as Caroline Miller. So I do mastermind sessions on Wednesday mornings, okay, and they go in a loop, so don't panic if you've kind of jumped in or have only jumped in a couple of weeks ago. Because they go in a loop of about 14 or 15 weeks. So we start off with cardiovascular risk and diabetes, heart disease, stroke and things like that. That's already been covered, but we will come back to that, don't worry. So we're now kind of moving on to the non-cardiovascular things, but all still related to weight and aging, I guess. Okay, so this morning we're going to chat about osteoporosis. Prevention is better than cure. Okay, so I don't want to know if anybody's necessarily got osteoporosis in this group, but can anybody tell me or what they think osteoporosis is and what it means to them? If you don't have it, someone in your family member or a friend may have it. You find that with most things.
Loss of calcium, weakening the bones.
Weakening of the bones, yes. Thinning of the bones. All right. Yes, Linda. Good. So bone thinning is essentially what osteoporosis is, and it results in weakened bones because as your bones get thinner, they become weaker, and that results in what kind of problems can we have?
Fractures.
Fractures, yeah. Okay. So, and I think even when I was a medical student to begin with, I used to sit and think, well, yeah, you get a fracture. That's not as exciting as possibly getting cancer or heart disease or something. But if you have a hip fracture over the age of 70, you've got it like 70 to 80% chance of mortality within 12 months. Okay. And that was one of the stats I think I was told as a medical student that I was quite, wow. You know, you just think people, yeah, they break things, but, you know, you go to hospital, you get it fixed and everybody's happy. That's not the case when you're older, okay? There's a lot of morbidity and mortality associated with fractures as you get older, and particularly big bones such as your hip or your vertebrae, okay? So you have an increased risk of fracture. Essentially, it's kind of asymptomatic, not unless you've got back pain because you've had a compression fracture in your vertebrae. So you don't know you've got osteoporosis, okay, until you've possibly had your fracture. And the fracture may happen due to a fall, or it may not. And I'm going to use my mum as a case study. I hope she doesn't mind. My mum is 78 years of age, and she's an archetypal osteoporotic lady. She's small, she's thin, she's never been overweight, but she's very small and slim and slight. Okay. And that does not go in your favor in terms of osteoporosis. And last February 23, she woke up and couldn't get out of bed one morning. And she lives in Ireland. And I wasn't told about this until about day 4 or 5 when my brother phoned me and said, can you please call, you know, I think I'd been on the phone and my mum had not, she hadn't told me. Anyway, I phoned and asked all the right questions. And yeah, she'd essentially got a spinal fracture and it was overnight. There was no trauma at all. Okay, and she ended up going and getting an MRI scan and a DEXA scan. And she was known to have osteoporosis before and had treatment for it, but things had got waylaid through COVID and she probably should have been reviewed again and treatment changed, etc., etc. Yeah, and she couldn't move for quite a few days, but there was no trauma at all. So that's really important as well. Okay, so it's asymptomatic. It's not asymptomatic anymore because she's been left with she has got a sore back now, although she's been dealing with that very well, but she just can't stand as long as she used to. She has to rest and things like that. And that's possibly not a bad thing because my mum was she's a bit of a warrior. She's one of those ladies who just never sits down. I'm sure you all know one if you're not one yourself. Okay. All right. So essentially the most common places for fractures are your wrist, hip and vertebrae, your spinal bones. Now, I'm not going to go into this in a great deal of detail, but I'm going to tell you a little bit about the pathophysiology, and that essentially just means what's actually going on when you have osteoporosis. So your bones are, and this blew me away as a medical student as well. Your bones, because you think of a bone as being a hard thing, you know, you'll see one in a museum or something, and you could clock somebody over the head with it, and I'm sure it'd be fairly sore. But your bones are an organ like any other organ, like your liver. It's a viscera, like your liver, like your kidneys, and they're regenerating all the time. Your bone structure is changing all the time. Okay, and there are two types of cells in your bones. And I said, I'm not going to go into this in a lot of detail, but I try and keep this very simple. So osteoclasts, 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 and they break your bone down. And then the ones that build your bone up are osteoblasts. And I like to keep it simple. So blasts build it up and clasts break it down. Now, before you hit the menopause and you've got estrogen, these two work alongside each other, and blast activity and clast activity is pretty much the same, and your bones are a reasonably good density. Okay, when you go through the menopause, your estrogen drops, so your blast activity drops. So you're now breaking more down than you're building up. And that's why you get thin bones as you get older. Okay. So how do we diagnose? Does anybody know how we diagnose osteoporosis?
Bone density scan.
Yeah, bone density scan, and that's a DEXA scan. And I chatted a wee bit about this last week. So DEXA scans would be ideal for looking at body fat, because they can tell you exactly how much muscle you have, how much fat you have, and what your bone's doing. But they produce x-rays, and they're incredibly expensive. And there's a waiting list in my health board, I'm sure, of about 2 years. So we're not using them to look at our body fat distribution. We use them to measure bone density. Okay. And the bone density, essentially what happens is the bone density is compared to that of a healthy adult, and your bone density reaches a peak, I think, when you're about 30 years of age. So you get your scan done, and then your density is compared to a healthy adult, and then the difference is calculated, okay, as a standard deviation. And the standard deviation is essentially just a measure of the variability based on an average expected value. So the 30-year-old bone density is a certain value, and your bone density is compared to that. And they work out how many standard deviations you are away from that. All right. You don't need to remember anything about standard deviations whatsoever. That's just how you get to the score, which is called a T-score. And the reason why I'm telling you about a T-score is if you ever go and have a DEXA scan, your physician may or may not discuss a T-score with you, but I always like to be in the know. All right. So essentially, if you get a number from the T-score is a negative number. So anything above -1 is normal. So you've got normal bone density. Between -1 and -2.5 SD, you've got something called osteopenia. So osteopenia is bone thinning, but you're not quite frankly osteoporotic. So if you remember when we chatted about diabetes, this happens in medicine quite a bit. There's normal glycemia, and there's being diabetic, and there's a bit in between. You don't go from having normal glucose levels to being diabetic. There's always a phase where there's a transition, and that's pre-diabetes. Well, it's the same with osteoporosis. Okay, your bones will have gone from being normal density osteopenia to osteoporosis. Now, you may never know you had osteopenia, because if you didn't have a DEXA scan, you wouldn't know. So you may have, had normal bone mineral density when you're younger. You get a DEXA scan done when you're older, and you're told you're osteoporotic, but your bones will have gone through a not so thin phase of being osteopenia, but it just depends when you get your scan done. Okay, any questions regarding that? No. Okay, so no. Right, I'm going to show you a picture here. I'm going to try and share the screen. Now, this isn't a great picture, but it's actually quite difficult finding decent pictures of this, I feel. Okay, if somebody can give me a wee nod and let me know if you can see that. Yeah, thanks, Judith. Right, okay, so it's not a great picture, but this is similar to what your physician will be looking at if you have a DEXA scan done. So we have a look at T12 down to L4. So that's your lower thoracic vertebrae down to L4, lumbar 4 vertebrae, and then your hips. So these are the two areas. They look at your neck of your femur and your lower vertebrae on a DEXA scan. And this is essentially, if I can blow this up a bit, I think, can I do that? Yeah. Right, let's do this. So this is the bone mineral density, grams per centimeter cubed. I don't look at this at all, okay? It's the T-score we look at. So the AP spine here, the T-score in this person is -2, okay? So they are osteopenic. They're not osteoporotic because it has to be less than -2.5. And then again, in the hip, you've got the left and the right, -1.7 and -1.9. Okay, so they're osteopenic. And this is the spine, and this is the femur here. And you can see this little dot shows you where they are. So they're osteopenic. They're not in the red down here. Okay, and obviously in the green, you would have a normal bone mineral density. Okay, so that's essentially, and this will also show you, there's different images you can get of this, and you can often see fractures, okay? And the people who report these will often comment on whether someone has a wedge fracture. That's where you can actually see the wedge fracture. Now you can go and get a specific MRI to look at your wedge fracture, as my mum did, but you can often see the wedge fractures, and they will be graded as well. And a wedge fracture just means it's like a wedge of cheese. So, you know, your vertebrae is thicker at one end and thinner at the other. It's a wedge, and there's different types of wedge fractures, okay? But that's what they mean by a wedge fracture, and that's essentially what's happening. The DEXA scan is looking at your neck of femur, and it's looking at your spine, at some of the vertebrae, not all your vertebrae. It won't tell you what's happening further up. But it will give you a score, and based on that score, the physician who's reporting the DEXA scan will then decide whether you need treatment or not. Okay. So causes of osteoporosis. Sorry, has anybody got any questions before I rattle on here? Hi, Sue. Haven't seen you for a while. Good morning.
Hi, no, just laugh. So I've been planning my things the way I should, so that's why I'm here.
Good.
But I'm still
Right.
getting dressed, so that was why the absence.
That's all right. So essentially causes of osteoporosis. So bone loss is a part of normal aging, okay? But some people lose it faster than others. Now, risk factors. I've said that obviously bone loss increases through the menopause and postmenopausal because your estrogen drops, okay? If you go through the menopause, the average age of menopause, and I'm going to do about the menopause in a couple of weeks' time, is about 51 on average, okay? If you go through the menopause earlier than 45 years of age, that's kind of looked on as early. Now, premature ovarian failure is under the age of 40 years, but an early menopause would be earlier than 45 years. Or if you've got your ovaries removed. So if you've had treatment to get your ovaries removed for whatever reason, because your ovaries are the organ that produce estrogen. Okay, and if you have your ovaries removed at an earlier stage or premenopausal, you should be put on hormone replacement therapy. And one of the big reasons for that is for your bones. Okay, we know people who go through premature ovarian failure or have to get a nephrectomy for whatever reason, removal of the ovaries, they have to go on hormone replacement therapy because of their bones. Okay, so essentially, up until we're 30 years of age, we kind of build more bone than we lose, and then gradually after the age of 30, the breakdown begins to outpace the formation, and this is accelerated around the menopause. All right, so that's why we get thinner bones. So other risk factors, gender, obviously females more than males. Males can get osteoporosis, but it is not as common. The clinic I used to do, yeah, I didn't see very many males at all. Okay, it's predominantly females. Now your bone structure and weight play a role in this, okay? And this is probably one of the things that being lighter and having a lower body weight increases your risk of osteoporosis. So if you're heavier, that's actually going in your favor. Doesn't happen very often. There are not many health benefits, I will tell you, of being heavier, I can assure you. But this is one of them. And I used to always think it was really funny because when I was training as a registrar, I did lots of different clinics, but I would do the lipid clinics like I do now, cardiovascular risk, and a lot of people would be overweight. I would do the diabetic clinics, lots of people would be overweight. You'd walk into the mineral metabolism clinic and all these little 70, 75-year-old ladies who were tiny would come in. It was really quite, it was quite funny. Because it was just such a shift. Okay, family history is important. So if I'm chatting to you about osteoporosis, I will ask, is there any family history? Is your mum or your sisters or aunts or whatever had osteoporosis? Also, when you started your menarche, when you start your periods, the earlier you start those, I think you've got an increased risk. Okay. Now, to be fair, by the time you're about 50, very few people can remember. I haven't a clue, what a rough idea, but I was never very good at that. So that was always, you never got a great answer to that, but I can appreciate that because I'd probably be hard pushed to tell you when my period started. Prior history of fractures important, especially fractures that aren't trauma. Now, if 10 years ago you fell off a mountain or a cliff and you broke something, fair dues, that's high impact. It's more if you've got a fracture without trauma, as in my mum's case, she had no trauma. It's picked up quite a lot with us with wrist fractures. So essentially an older person will fall, and as a result of getting a fracture in our health board, that kicks off you automatically at a certain age. Now, if you're 25, you won't, but if you're older, if you have a fracture of any type, you will get referred to the DEXA service. So you get your DEXA scan, and then if that shows osteoporosis, then you come into the system to get treated. Okay, or the DEXA scan's fed back to the GP. So if you've got so history of fractures is important. Okay, and then the other thing we need to chat about is medication, because steroids are renowned for increasing your fracture risk. And in my mum's case, it was it's like most things, lots of things came together. So basically she had osteoporosis before COVID, had treatment for it for 5 years, but she was on a bisphosphonate holiday, and I'll come back to that. COVID then happened, so she didn't get a repeat DEXA scan. She then, about 2 or 3 months before she had her spinal fracture, was diagnosed with polymyalgia rheumatica, as a lot of older patients are, and she was put on steroids. She'd been on steroids for about 2 months, and next thing she gets her spinal fracture because the steroids had just added insult to injury as far as her osteoporosis was concerned. Okay, so she obviously had thin bones, and then we give her a dunt of steroid. Okay, so it wasn't great. All right, so, and that brings me on for treatment for osteoporosis. So first line treatment for anything is prevention. So prevention is better than cure. The problem with osteoporosis is we can use medical treatment to slow down the bone thinning or maybe hold it for a while, but we can't fix. There's nothing they will give my mother that will fix her vertebral fracture. Okay, that job's done. There's nothing can do about that. So prevention is better than cure. So first line therapy is fall prevention. So anybody that is osteoporotic, we sit with them for a while and take a lot of time explaining how you have to change things around the household. And when she went actually to see her spinal surgeon, he basically told her she couldn't afford to fall again. Okay, no, she didn't fall in the first place, but he basically just said you can't fall. If you fall, you're gonna have real problems. Okay, and by real problems, I mean if you have a problem with a spinal fracture, you can affect the nerves coming out of your spine. So she had worsening advice, i.e., if she can't pass urine or she can't open her bowels, she has to go to A&E immediately because she could have a compression fracture that's affecting her, the nerves coming out of her spine. Okay, so prevention, really important. So hints and tips for anybody that has older parents: please remove any loose rugs in the house. They may look nice, they may have had them for 20 years, but you need to remove them. I remember doing this in my father-in-law's house several years ago. So you remove any rugs. Low-lying tables, be very careful as well. Magazines, books, all need to be put away. Make that quite easy, somewhere that you can put them into at the end of the evening or whatever. And if needs be, handles, occupational health into the house or the flat to ensure there are handles, for getting up and off the toilet. or showering, things like that, just all the aids that just decrease the risk of falling, and no high steps and railings, and use them. Okay. So I had my mum, I digress again, my mum was away with us in Portugal this year for the first time since COVID. And I insisted that we carried everything for her. And I heard her outside chatting to my dad. My dad doesn't travel anymore, so she was chatting to him out in the garden. And all I could hear was, oh, they won't let me do anything. They're carrying everything. They're doing this, that, and the other. So she really does not want to lose her independence. But I kind of reminded her that, A, I did not want to end up in hospital with a hip fracture. With her in Portugal, and B, my son who's 12 lets me carry everything and do everything for him. And I said, so just see what he just loves it. I said, so just relax and let us open doors. You know, there were lots of steps where we were, and I just wanted her to concentrate on holding on to handrails and doing that without worrying about carrying a bag. But it is difficult because she's obviously carried her bag and done her own thing for 70 plus years. But yeah, so prevention is better. If she doesn't fall in the first place, she shouldn't break her hip. Yes,
Caroline. So I thought that part of the antidote and part of the prevention was weight bearing exercise for bones.
It is, yeah. But yeah, no, I know. So you're wondering why I'm carrying stuff for her. So it's essentially because she's 78. She's got a spinal fracture that was pretty horrific, and we're kind of not past the weight bearing. And she does do around the time of the spinal fracture. She couldn't do anything for, I can't remember how many weeks it was. I think it was 12 weeks. She was told literally not to do very much. But she's a walker, so she was walking or shuffling, and then she was starting to walk, and she did get some physio exercises. So the carrying of the bag on holiday was more, the area we were was very cobbled. So,
Okay.
you know, I'm happy enough for her to do light weights at home with it, like literally a tin of beans, or, you know, just lifting her legs or arms or whatever. But I wasn't prepared for her to be carrying her bag, which, you know, invariably had, you know, bottles of water and everything, because it was really quite warm. So yeah, I think, yeah, the trade-off was we can worry about the exercises some other time, but when we were away in a foreign country, I wasn't trying to take any chances. I just wanted her to concentrate and not going ass over tit, so to speak. All right.
Yeah.
But yes, you're right, weight bearing, and we'll come on to that. So prevention, fall prevention, make sure you make your accommodation or wherever you are less likely, you know, in a position that you're less likely to fall. Treatment for further prevention, yes, you're right, exercise. So regular weight bearing to make your bones and your muscles stronger, and prevents further bone loss as well. So in our case, everybody that's doing the resistance training, whether it's resistance bands, body weight, or indeed lifting weights at all, you will be doing your bones some good, which is really good. The other thing that really is good is balance exercises as well. So Alex did this quite a while ago when I was going through TSD. And I always say this with a bit of fear, because I usually set it as a challenge at the end of this one. It's to stand in one leg doing your teeth in the morning and the evening. So if you stand in your left in the evening and your right in the morning, or vice versa, it's really, really good, your balance. So you've got receptors in your ankles, okay, that tell your brain what your tendons and muscles around your ankles are doing, so that you can keep, and that's the more you keep on top of your proprioception and your balance, the less likely you are to fall. Okay, so it's just simple things like that you can do every day. And it's funny, my PT gave me my exercises changed this week. So I was, after I'd done my squats and my deadlifts last night, I was doing, it was single leg RDL things, and he links all the stuff to YouTube videos. And I've done lots of RDLs before, but this one was you literally lean right over with your back leg, one of your legs going up. And of course I'm looking at it, and I think last week I was doing barbell RDLs with 25 kilograms, and I'm looking at this thinking, ooh, that looks a wee bit more difficult. So I thought, I'll start with 5 kilograms. So I've gone from 25 kilograms with a barbell down to 10 kilograms with my dumbbells. And I went over in the left-hand side, and I nearly went ass over tit. And I thought, oh, right, okay. This is going to take a little bit more coordination because I'm lifting a leg off the ground, whereas before from my RDLs, I keep both legs on the ground and, you know, bend over more to do the stretch and the pull. And it just shows you. So I thought, oh, maybe I won't be putting the weights up as quickly. But as I was doing it, when I was in the 4th or 5th in a set of 8, I could feel the proprioception in my ankle. You can feel it. And if you stand tonight and do your teeth in one leg, you will feel your ankle moving. And that is your proprioceptor, you know, your proprioceptors will be firing off loads of information to your brain to keep you upright. Okay. Because your brain needs to know what where your ankle is and what it's doing. And interestingly, that's why if you, I'm not suggesting this, if you have an amputation, you want the joint, or if you can. So say you're going to have an amputation, you want a below knee amputation, okay, because you want your joint from your knee as opposed to a bovie knee amputation with a stump. If you have a choice, depending what's wrong with your leg, possibly you're a diabetic and you have to have an amputation because of vascular disease. You want the joint because the joint is what's going to speak to your brain. So having that prosthesis, your false leg, you'll be able to walk better if you have your joint. Okay, and that's all. And that's obviously got nothing to do with osteoporosis, but it's just an interesting aside. Okay, so regular weight bearing exercise improves your bones and your muscles, and we're going to chat about muscle in a wee minute as well. It prevents bone loss, and also the balance and the strength helps avoid falls. Okay, so again, prevention is better than cure. If you're stronger and your muscles are stronger, your tendons and your joints are all stronger, the chances are you're not going to fall. If your muscles are stronger and you do fall, they should protect your joints as well. If you've got strong quads and you fall, you're less likely to damage your bones underneath. All right. Nutrition is important. What kind of things do you think we need from a nutrition point of view?
Dairy for calcium.
Yeah, so we want dairy, we want low fat yogurts, but we want dairy and skimmed milk. And this brings me back to Alex's fridge. He did this several weeks ago. Everybody was putting a picture of what was in their fridge, and Alex must have had about, I don't know how, it was about 10 cartons of skimmed milk. They obviously go through a lot of milk, but there'll be a lot of calcium in that. Dark leafy veg, kale and broccoli. Okay, and fortified cereals, because we want calcium and vitamin D, don't we? Because vitamin D, we make that in our skin, but unfortunately, the further up north you go, the less likely you are to have a lot of vitamin D, and I will be making very little between October and March, I would argue, because even if I am outside, I'll be completely covered up, bar my face. So vitamin D is very important because vitamin D is involved in the absorption of calcium from your gut, and calcium metabolism and vitamin D are tightly linked. Okay, so the other treatment is medical treatment. Okay, does anybody know the first line? There's a tablet we can put you on if you have osteoporosis, a class of tablets.
Bisphosphonate.
Bisphosphonates, yeah. Okay, so bisphosphonates are the first line, and if you can, these will be prescribed to take orally. So you'll take 1 tablet a week, which I always think is quite difficult. I always suggest a Sunday morning. I don't know why I suggest a Sunday morning. I always think people will be possibly less busy on a Sunday than a Monday, even if they're retired, because lots of patients with osteoporosis are retired. But yeah, taking 1 tablet a week is quite difficult. It's possibly a wee bit easier now if you've got a smartphone, you can set an alarm, but 1 tablet a week is quite difficult. Bisphosphonates, what can I tell you about bisphosphonates? Everybody describes them as horse tablets. I don't know why people tell me they're like horse tablets. I don't have a horse. I have no idea what kind of a tablet a horse would take. But horse tablets, I take that as a large tablet. Okay, I haven't even seen my mum's actually, because presumably I'm not. I go home every so often, but I don't see her taking hers once a week. Horse tablet, so it's a large tablet. The advice is to take it with a big glass of water. So I would suggest a pint of water, and you should remain upright. It can affect your esophagus or your gullet. Okay, so you should remain upright for at least 30 minutes. And in clinic, I often suggest to the ladies, if they have any ironing to do, why don't they take their tablet once a week and then do half an hour of ironing? Because that means they remain upright. Okay, because gardening or houseworking or doing anything else around the house, not so much, because you might bend over quite a bit, but ironing, you don't tend to bend over, you keep fairly upright. there's no evidence base behind ironing and taking your bisphosphonate. It's just a suggestion we come up with in clinic. Okay. All right. So bisphosphonates are very popular. You'll often be put on 5 years of those. You should have a DEXA scan every 2 years, I think. But again, that may now all have changed because of COVID and waiting lists and things like that. But if you're on your bisphosphonate, you will then also be asked to take calcium or vitamin D supplementation or both. When I started as a registrar, we had everybody on calcium and vitamin D, and then we changed everybody to vitamin D. Calcium supplements aren't very pleasant to take. They're quite chalky. Vitamin D are okay to take. They're kind of wee squidgy capsules, I think. And you can either get prescribed those or take them over the counter. I don't think anybody should take supplements without getting their levels measured. Okay, case in point, back to my mum. My mum's a cracking case, okay, for all sorts of things that didn't go well. She was put on calcium and vitamin D supplements, and I don't think they had measured her calcium. They just put her on the calcium vitamin D supplements. My mum's tiny, she's 5 foot nothing, okay, and she was taking so many tablets, and all of a sudden she got constipated and got a very sore abdomen. But at the time, she didn't, I don't think she'd had the spinal fracture at this stage. I think she'd just been put on the steroids, and I'd drawn them to the fact that she had osteoporosis. Anyway, she got quite horrific abdominal pain. So of course, what did we all think? She's 78. I thought she had ovarian CA. All right. And nobody was talking about this. But it was essentially, she then admitted that whatever she'd been prescribed, she'd taken, I think it was like 30 odd calcium tablets over 2 or 3 weeks or something that she'd been prescribed. She'd taken them as she'd been asked to take them, but she was tiny. Okay. So we stopped the calcium tablets. We hit her with the prune juice. All right. Everything worked out okay. And then I asked for calcium to be measured, and our adjusted calcium was 2.4. It was plumb line right in the middle. Calcium range is 2.2 to 2.6. She didn't need calcium supplementation. She's got a very, very good diet. So we then get the vitamin D measured, and we replaced vitamin D, not the calcium. And she hasn't had any problems since. So you've got to be really careful with supplementation. It's not something, I don't think everybody should just take supplements. Okay, I think you've got to have, and especially if you've got a good diet. All right, because you can run into problems. And as I said, you can get lots of calcium and vitamin D from cereals and your dark leafy green veg, kale, broccoli, and your dairy products. You also have to be careful if you've got too much calcium as well as constipation, taking the supplements, you can get kidney stones. All right. Some people don't clear calcium as well, and when it's hot and you're not taking on enough fluids, you can have problems, increased problems with kidney stones. So if you've had a problem with kidney stones before, you have to be careful with your calcium intake. Other treatments for osteoporosis, there's a monoclonal antibody called denosumab, which you can get, and I'm not going to go into that in detail because that would be started by secondary care, I think definitely in our health board in Scotland, and that's an injection you would get once every 6 months for so many years. And then there's another one if you're severely osteoporotic and have real problems. There's teriparatide, and that works by mimicking your parathyroid hormone, which is a hormone that's released from your parathyroid glands that's involved in calcium and vitamin D in your bone metabolism as well. Okay, but again, that would all be directed by tertiary care. Okay, your GP wouldn't be prescribing that, I don't think. Okay, vitamin D, the sun. Okay, 20 minutes per day in the sun, or eggs, fish such as salmon, and cereals. All right, and it's required, as I said before, to absorb calcium. Smoking. You know me and my smoking, so just a little aside on smoking. It causes the body to make less estrogen, okay? And alcohol does two things. It damages your bones. We can actually see that people who drink quite a bit of alcohol will change their mean corpuscular volume, MCV. It will be bigger, and we can tell that you're a drinker from your bones. Wow. Okay, and also if you drink, what else can happen?
Gain weight.
Pardon?
Gain weight.
Gain weight.
Fall over.
Well, no, I'm thinking falling over. Yes, falling over. That's exactly what happens. So prevention is better than cure. If you drink a lot of alcohol, you're more likely to fall over. All right. So the whole idea of the treatment, the treatment goal, whether you're looking after your nutrition, doing your weight bearing exercise, making sure your house hasn't got trip hazards, or medication, is prevention of fractures. Okay, so your hip and your vertebral fractures. So diet and lifestyle is incredibly important. So any questions? Because that pretty much covers osteoporosis. Carolyn.
I have osteoporosis and I'm taking 2 calcium and vitamin D tablets a day and alendronic acid once a week. And I was told that I had to take the calcium for the alendronic acid to work. Nobody's ever spoken to me about it. I've never physically spoken to a doctor. It was all done by letter, really. Should I ask to have my calcium measured?
Yeah, I think so. You're correct. The alendronic, for any of those medications, so for the monoclonal denosumab, the teriparatide, and the bisphosphonates, you shouldn't be started in any of those without having, you know, calcium and vitamin D levels within the range. Okay. But I think the problem with my mum was the fact that her calcium was okay, and then we give her calcium and it resulted in constipation. Now you're obviously taking your calcium and you possibly don't have constipation. That's fine, but you just have to be careful. Yeah, I think it's because, well, I know a lot more. I wouldn't go on something without knowing what my level was. All right. But that's fine because I'm in the know and I sit in the biochemistry lab and my guys measure stuff and I know exactly what I'm talking about. But yeah, I think I don't think people should just be put blatantly on things. Now, it might have been at the beginning your calcium was measured and it was at the lower end of normal, and you know they wanted to give you calcium and vitamin D, and that's fine. But yeah, I think asking to get your calcium and vitamin D done. Now, vitamin D is one of those things. Vitamin D became very trendy. I'm going to say 5 years ago. It's probably more than 5 years ago now because COVID, the end of COVID was 3 years ago. And vitamin D has been related to lots of stuff. Now, whether there's actually a causal relationship or not is difficult to tease out, but it's been shown to, you know, be linked to quite a few things. And as a result of that, everybody wanted their vitamin D measured. So the vitamin D requests by GPs and secondary care went absolutely through the roof. And as the biochemist, we measure it. So we now have an intervention that you can only get your vitamin D measured once every 340 days, which is essentially a year, once a year. Okay. And you don't need it measured any more than that, not unless you've got a problem with your kidneys or a disease that affects your vitamin D. Okay, so there is a caveat. There will be patients that we do measure vitamin D on more frequently, but I'm not going to go into that. But in general, the general GP patient needs their vitamin D done once, and then you just take supplementation. Okay, that's fine. But yes, I think you should have your calcium, vitamin D. I would be hard pushed to take anything without having my levels measured. Okay. But yeah, it's something you can go, you know, you could say to your GP, and that's the other thing, people get put on things and just left on them. You want your calcium and your vitamin D to be replete so that you're taking your alendronic, your bisphosphonate, and it's working. Okay. But you also don't want to over supplement either, I would suggest. So I think, you know, you could ask your GP just to measure your calcium. I think that would be fine. Okay.
Okay, thank you.
But you need to ask there. I can't really give personal advice. You need to ask that, you know, what your GP's policy is and what their advice is. I think definitely post-COVID, lots more things are happening via telephone and letter as opposed to a face-to-face, and lots of practices will have changed, I think, you know, in terms of monitoring bloods and doing bloods and things like that. However, I think as an individual, you can ask. Okay. Yes, Linda.
Is stenosis of the spine a type of osteoporosis?
Stenosis of the spine?
Yes.
Pass as the answer to that one. I don't think if you've got, by stenosis, do you mean like the fusion of your vertebrae?
It's my mother. They were described as a narrowing of the spine, or the I think there's a loss of calcium at the base of the spine.
It could possibly be related to osteoporosis, and presumably if it's your mother, she's an older lady. Yeah, it may be due to osteoporotic changes, but again, that would be, they would be able to answer that using a DEXA scan. They would be able to say whether she's got osteoporosis or not, or osteopenia. But the only way you can really say that is by getting a DEXA scan.
Okay, thank you.
All right, but it sounds as if, yes, if her bone shape has changed, osteoporosis will have had some play in that. Okay, Sue?
Just wondering, I'm on thyroxine, and just recently my thyroxine or the TSH levels were like very depleted. So they said I needed, I think it's that way around, I needed more thyroxine. The problem is that from reading some of the inserts, it does affect your bones if you have too much. So you need to balance that. But they only ever take my TSH. They don't ever do T3 and T4. What I mean, if you are overdosing, what is the impact on your bones? Because I'm fair-skinned and blue-eyed. What like, is there something I need to go to the GP with and go, this, there's an osteoporosis?
Yep. So in terms of, so people who are hypothyroid can put on thyroxine, and one of the side effects of thyroxine, you need the thyroxine if you're hypothyroid, but there are two side effects of over-treating with thyroxine. One of them is, in older patients in particular, is atrial fibrillation, and which is a kind of your heartbeat not doing what it should. All right, for want of a better word, it's a dysrhythmia, and thinner bones, osteoporosis. So when you're talking about TSH and free T4, so essentially some labs, our lab, for example, we measure free T4 and TSH on everybody. We don't measure just TSH, but there are lots of labs in the UK that just measure TSH because it's one test as opposed to two, so it's cost cutting. Okay. Your TSH though can tell you if you're over replaced, because what will happen is your TSH will have a range, and for example in my lab it's 0.35 to 5 milliunits per litre. That's our range. If your TSH is less than 0.35, that would suggest you're over replaced with thyroxine. Okay, now in younger patients, and this is where it gets quite difficult, sometimes when your TSH is suppressed a bit more because you're taking a wee bit more thyroxine, that's fine because clinically you feel better. And if we reduced your thyroxine and your TSH comes into the normal range, you may not feel as good as you did. Okay, so that there's a trade-off. You have to decide between you and the patient what kind of dose you're going to sit at and not over replacing. So we would look at the free T4 level that the free T4 level, and make sure that wasn't too high, because you can have that in the normal range but still have a suppressed TSH. If you're older and you've got osteoporosis, or you've got an increased risk of osteoporosis because you're older, you're postmenopausal, yes, then you might possibly you would want to keep your TSH within the range, in which case you would take less thyroxine. Okay, because you want to keep your TSH up a wee bit, because there is evidence that having too much thyroxine can result in, or kind of have affect your bones. Okay, so that's something, again, you need to just chat with your GP, or whoever looks after your thyroid.
But it's interesting because they just said to me, your cholesterol's at 7 and your TSH means you need more thyroxine. You need to take more thyroxine because as soon as you take it, your metabolism will increase. But when I push it up, I start getting the palpitations and I really don't feel well. I think 125 milligrams without testing all the other stuff, but I don't know what argument gets presented, and I don't want osteoporosis. So I don't know what I need to say.
Well, I just guess you need to say, well, I don't know how I'm getting on with my my thyroxine, and can I have a full profile done? You don't need to do T3, I would argue. Okay, but they should be able to do free T4 and TSH. Okay.
Okay.
But the GP needs to then be able to interpret that. Okay, whoever's ordering it needs to be able to interpret it correctly. All right.
Yeah.
Okay.
Yeah. Thank you.
yeah, it's difficult. It's difficult even when you have a medic in the family at the moment, I think.
So with should you continue on HRT to protect yourself, your bones?
Well, HRT will help your bones, yes, because obviously, you know, the hormone replacement will help your bones, but it's not that there's lots. HRT is really complicated, and I'm going to do a menopause session, Daryl, in a couple of weeks, okay? And we'll chat more about HRT. HRT is really, really individual. There's lots of different things, you know, whether you've got a history of heart disease, whether there's a family history of breast cancer, or you've got a history of breast cancer, and yeah, what you know, that kind of thing. HRT is obviously going to help your bones, but you don't take HRT out with the other issues with HRT and risks and benefits just because of your bones. Okay.
Right.
All right. So yeah, that's actually really complicated. So again, that's a discussion you have to have with your own GP. Okay. HRT is just a minefield, and I get asked about that all the time now, and I don't prescribe HRT.
Yeah, because basically my GP originally wanted to take me off because she said, oh, you're coming up to 60, even though I went into menopause very late, at 58. And I said, oh, no, I'm not coming off yet. And then you hear women who are still on HRT at 80. So you think, whoa. Well,
yeah, and again, that's not my specialist field, and there'll be more evidence coming out regarding that. But it's a discussion you have to have regarding HRT, you know, breast cancer risk, heart disease risk, but it will protect your bones while you're on it. But whether that's a good enough reason to stay on it, if you've got risk factors, you know, for heart disease or breast cancer, you know, that's all. Yeah, and I think most of the evidence that we have so far protecting against heart disease is taking HRT up to the age of 60. And I don't think we have the evidence post 60 yet. But as you say, there are people who are on HRT at the age of 70 or 80. But I guess if you get to 80 and if you haven't had any of the above problems, you could argue, why would you not? Do you know what I mean?
Yeah.
So it's easy to turn around and say, yes, somebody who's, you know, I don't know if I'll take HRT when I'm 80. I don't know. Okay. I'll take it as I go, and I'll weigh up the pros and cons as to what my health's like at the time and what my other risk factors are. I think HRT is a very fluid thing. I don't think it's something I can say I'm, you know, 50 and I'm going to take it until I'm 80. I don't think I can say that, because I think my risk will change as I get older, depending what happens. Okay. You know, so I don't think it's as simple as that. I think the HRT conversation is really quite complex, and I think it's really, really individual. I don't think one brush, you know, suits all. I think it's going to be very big, and rightly so. I think it should be very big, but I think going forward, hopefully we will have a lot more menopause and HRT specialists. Okay.
Yeah.
I've just joined, we see this for a laugh, Alex would wet himself. I have just signed up to be not an HRT, a menopause person at work.
Excellent.
People who can come and chat to me. Although I'm so busy, I missed the first. Well, I thought I missed the first meeting. I couldn't go to the first meeting, but I think it might be next week instead. So there you go. So
menopause champions rule. Me too.
Well, I had an interesting question, because we, from a biochemistry point of view, and I digress because we're not chatting about menopause this week, but anyway, lots of ladies are getting put on testosterone. Okay. Now, my simple, and this is very simple understanding of testosterone, is all females have testosterone. We have very low levels of it, the same way all males have estrogen. Okay. We don't routinely measure testosterone in females, but in our biochemistry department, we've got a very specialized unit that does an androgen profile. Now, androgen profiles are used in young people to look for a couple of things, one of them being PCOS. Okay. And also, which is polycystic ovary syndrome, and also weird and wacky adrenal issues like congenital adrenal hyperplasia and things like that. And there are things that can go wrong that can affect you, and there are tumors. Okay, so if I measure testosterone in a female, just for whatever reason, in an androgen profile, and it was found to be high, the first thing you would think of in a young person is that, well, one of the things, it's not necessarily, they don't necessarily have a tumor, but that's one of the things you'd want to rule out. Okay, there are now menopausal females who are taking testosterone, and I don't think the guidelines are there. So I was doing a CBD, I was at a seminar, it was from someone down in England, was on. I think it was Yorkshire, possibly, can't remember. Anyways, chatting away. So I asked a question at the end. I typed it into the Teams chat and I said, oh, what's the kind of evidence for taking testosterone as part of your HRT in females? And you know, it's the usual, because my husband and I chatted about this, and he's like, you're not going to get a deep voice and hairy this and hairy that. And he's right. If you take too much of it, you will get a deep voice and a hairy this and a hairy that. But my question was really around the long-term effects of testosterone. How do we know how that's going to pan out if we give ladies high doses or higher doses of testosterone in terms of a cancer? And I don't think she didn't answer that question. She just told me the hairiness and the you know, and all that kind of stuff, because they won't have the results to that. So I think we're going in somewhere that we don't have, you know, we don't have a lot of evidence. We don't know what's going to happen in 5 to 10 years' time to people who have been taking testosterone as part of HRT. So I think it's something that you have to kind of think about. I think one of the main reasons people go on testosterone around that time is for libido. Okay. But we measure it in lots of females now, and we're getting so normal. I can't remember the units, apologies, but normal was less than the figure I have in my mind's 3. We're now measuring testosterone in females that are 8 or 9. And if I measured a testosterone of 8 or 9 in a young female, you'd be straight on the blower to the physician saying, you know, this is a really high testosterone, something's going on here. It needs investigated. That's not normal for a female. So I think there's, yeah, it's a complex conversation, okay, and it has to be all individual. All right. Okay, so sorry, I shall cover the menopause. I can't remember whether it's next week. I don't know. I can't remember. There might be some liver stuff in between. I can't remember. Right. So just to finish off, I'm going to chat 2 minutes. I always sit and look at my watch at past and think, God, I'm about to finish and I've got hardly anything left to say. And next thing it's 5 to 9. And it's like, ooh. Right. So sarcopenia. Okay, very, very quickly. So sarcopenia is the loss of muscle. And I find this really, really interesting because it's not, I hadn't thought about this at all. And I don't think I ever covered this in medical school. To be fair, medical school was a while ago, so we probably didn't chat about this. So it's essentially, you know, osteopenia or osteoporosis. Sarcopenia is age-related loss of muscle mass and function. Okay, so I had a good tool when I first did this, when I was doing osteoporosis for the Wednesday Mastermind. I had a good look at quite a lot of the evidence, and particular, I used the British Geriatric Society. Okay, so they think this basically affects 9 to 18% of people over the age of 60. So what's the underlying cause? They don't really know. Okay, and again, is it? I think lots of things happen at once. It's a wee bit like the weight gain thing around menopause. Your weight gain around menopause is not just because you're going through the menopause. Okay. I think it's the change of lifestyle around that time of life. And I've said this before, when I was 20 years ago on ward rounds, I was on my feet 12-hour shifts overnight during the day. I now sit at a computer most of the day. Okay. And I have to go for walks in the morning. I have to go for walks at lunchtime or in the evening. I have to move my ass, and I have to make sure I do it. Completely different job to what I used to do. Okay. I also don't have a toddler at home anymore. All right. So lots of things have changed. And up until starting TSD, you know, in my early 20s, I was, you know, playing badminton, doing this, doing that. And then I had a family and did exams for my career that, you know, all my extracurricular sporting activities fell to the side because, you know, I had a family and I had a career, and there's only so many balls you can juggle. And it's only now that my son's older, I've thought, right, we need to do something about this. Okay. So I think there's lots of things. I think, yes, we do. I think there's the slowing down, you know, we're not doing what we did when we were younger, and also we get older. The sarcopenia is linked to falls, a bit like the osteoporosis, and it results in impaired activity of daily living and institutional care. Okay. So it's really important we do something about this. So they don't know exactly why it happens, but we do know as people get older, they lose muscle mass. Okay. I look at my father, he's in his late 70s as well. He was never particularly sporty or active. They used to tell me they found me at the side of the motorway, but that's another story. And he's always complaining of aches and pains, and I sit and think, but you hardly move. All right. So if you hardly move and then, you know, you go and do something, how can you, how do you expect? And it was really, I had this lovely lady in a couple of weeks ago in clinic, really, really nice lady. And she said to me, she said, I can't clean the whole house anymore. Now, my first thought was, why would you ever want to clean your whole house in one go? But that was an aside. I didn't say that to her. It's just a personal thing. And then she said, yes, I can only either do the downstairs or the upstairs. And she was in her late 70s. And she's in with, she must have been in with high cholesterol or whatever. And I kind of said, but yeah, but I said, do you do any other, you know, do you do any other exercise or anything, right? Whatever. No. You know, so she's in her late 70s. She's slowing down. She has slowed down, and she doesn't do anything to kind of maintain, you know, and I wasn't going to go down the whole how the resistance bands or the press ups going. Do you know what I mean? She hasn't done that, and that's really difficult. So the idea is, yeah, and she's 78, so maybe when she was 50, 55 or 60, if she'd started, you know, I'm going to get my steps in, I swim or I cycle, and you won't be able to do as much when you're 80. I get that, but the whole idea is now, if you lay down the good habits, you know, I surmise presumably my weightlifting is far better now than it was 2.5 years ago, but at some stage I'm not going to be able to lift the same weight, am I? That's going to go down. But if I can still lift weights, it's still, you know, it's still it's still a bonus kind of thing. So one of the things, so they don't really know why sarcopenia happens, but we do know what happens. Your muscles aren't, you kind of lose muscle mass and function. So what are the risk factors? Increased age, low levels of physical activity, inadequate nutrition, and comorbidities such as type 2 diabetes, heart disease, and things like that. Okay. And that lady probably ticked all those boxes. Okay. So she had all the risk factors. I don't chat to any of my patients about sarcopenia, but that's too busy because I'm too busy chatting about cholesterol and I've got 9 minutes or something. But it was interesting that she just kind of, you know, said, I can't do X, Y, and Z anymore. So how do you diagnose it? There won't be a formal diagnosis. There's no way in this earth GPs are diagnosing sarcopenia, but it's impaired physical performance, slow gait or speed, and low muscle strength. And you can do that with hand grip things. So how do we counteract this? Resistance exercise, increasing your protein plus or minus vitamin D. All right. So all the things that TSD have kind of, you know, you've increased your resistance training, whether it's body weights, whether it's resistance bands, or whether it's actual weights. So you want to keep going with your resistance training. All right. Okay. So that's sarcopenia. So two things that happen as you get older is your bones get thinner and your muscles, I was going to say disappear there. They don't disappear, but you know what I mean. But it's all good, and you'll know that if you've done any resistance training and you've done it for any. I mean, you've already done 12 weeks of TSD, and irrespective of whether you can see them or not, you'll be able to feel them. I remember one of the first things Tristan said to me was, he said, "Oh, you've got guns." Now I was quite excited. Little bumps in my arms, okay, and I still have them, and it's all good. Right? Any questions about sarcopenia? I think Alex on Monday was chatting about, or it's maybe the previous Monday, about the 100 grams of protein. No, he didn't Monday, did he? Did about how do you maintain it, didn't he? So he was making sure you keep doing the exercise you enjoy and keeping your protein up. All right. Okay, so that is osteoporosis and sarcopenia. All right. Lovely speaking to you all again this morning. Have a good day. It's got a bit colder up here, but it's still sunny. So we're taking that as a win. But the temperature's dropped a wee bit, which isn't a bad thing. I don't think anybody, it's funny in Scotland, we all like the nice weather, but not if you're going to school and going to work. Because we're not really equipped for it, are we? Right, or my office definitely isn't. Right, have a great day, and I shall catch up with you next week. Morning, Danielle. Have a good one.
Thank
Okay.
you.
Thanks.
Bye.
Bye.